and welcome back to our mini series of webinars relating to the Maple Basic Training Day. So here in this webinar, we are looking at the electrical stimulation function of the Maple device. So there's a really good website by Tim Watson, Professor Tim Watson, www.electrotherapy.org. So we have to think of electrical stimulation as the delivery of energy to the tissue that will bring about physiological changes in the tissues, thereby achieving a therapeutic benefit. The critical issues are to set the machine in such a way as to stimulate the target nerve as effectively and as efficiently as possible. Stimulation of sensory nerves will achieve a sensory outcome. Similarly, stimulation of motor nerves will bring about a motor effect. Clearly, it is not possible to only stimulate one type of nerve or another, but it is possible to primarily have an effect on a nerve type by setting appropriate parameters on the stimulation device. So that's a quote from Professor Tim Watson's website, which I find really useful because when using a Maple device, same as any other electrical stimulation device for therapeutic benefits, it's important to get the parameters right. So with electrical stimulation, we are passing electrical current through the motor unit, which is the efferent nerve, and sensory nerves, the afferent nerves, in order to artificially activate the muscle fibres to increase independent activation, leading to increased movement, bulk, power and confidence and connection. And also we can use electrical stimulation to ease pain from muscle overactivity or smooth muscle irritation. So it's important here, the title says Maple EMS, that would be electrical muscular stimulation, but we are also looking at the easing of pain, maybe from muscle overactivity or from nerve irritation, so that should really be ES, electrical stimulation, because it's not always electrical muscular stimulation. So here is a list of contraindications and precautions. So pregnancy obviously is a contraindication to electrical stimulation of the pelvic floor. Any malignancy that is present, especially within the pelvis. If there is a neurostimulator present, so don't use Maple for electrical stimulation if there is an SNS present, and also pacemaker. If there is psychogenic pain, that you shouldn't use electrical stimulation with that. If there is any severe skin or tissue conditions, so acute inflammation of the perineum, vagina or anus, and severe atrophic vaginitis. Now, when patients are in the middle of treatment and they come in for a session and there has been a change to the vaginal tissues or the rectal tissues, quite often they will say, I'm absolutely fine, carry on with treatment, but remember that there is a contraindication to use of electrical stimulation in such cases. So you might have to have a difficult conversation with the patient to say, Maple treatment may not be the best course of action today, but we will get treatment sorted to help ease those problems. If there is an inability to understand or tolerate treatment, that would be a contraindication, and also excessive vaginal bleeding, especially unexplained or postmenopausal bleeding. That should be seen by one of the medics in the first instance. You can use the Maple device for electrical stimulation during a period, as long as the patient is happy with that. So it's dependent on consent. If there is excessive vaginal bleeding, then we need to work out the cause of that before going any further with electrical stimulation. So the list of precautions here, immediately postpartum we wouldn't use Maple. We tend here in Station House to work on nurturing the first 6 weeks for recovery and rehabilitation without any therapeutic interventions unless absolutely necessary. So we do have a precaution there, but if one of the patients really needs to get their pelvic floor working and is actually more affected negatively by the lack of treatment, then obviously that precaution can be looked at a little closer. Poor skin condition, especially if this is normal for that patient and they are under treatment and it is not worsening. If they have reduced sensation, so absent sensation, obviously we wouldn't use electrical stimulation. Reduced sensation we would need to use with caution. Previous malignancy that has either been removed or successfully treated, we would need to monitor patient symptoms and also get the go-ahead from their oncologist. Body piercings, remember with electrical stimulation, if there is direct contact with metal, then we need to be careful. An IUD, so if there is a Mirena or copper coil in place, that is a precaution. Some therapists continue vaginally, other therapists will use the probe rectally. This is something we can discuss in the basic training day. Haemophilia, epilepsy, history of sexual abuse, these are all precautions, not contraindications, remember. You've got to take it on a case-by-case basis. Vaginal bleeding, especially if the patient is not consenting, and reluctance or fear from the patient. So those would be your contraindications and precautions. So going into electrical stimulation for the skeletal muscle fibres, we need to remember that we have got fast twitch fibres and slow twitch fibres, and different parameters of electrical stimulation will target different fibres within your muscle complex. A beta nerves are type 2 or touch nerves, so sensation nerves. A delta, a type 3 temperature, pressure or pain. And type 4 is for chronic pain, C fibres. So these are the nerve fibres. Now, we need certain settings to access activation and release of the fast twitch fibres or the slow twitch fibres. What we need to get is a sensation of touch and movement, but not necessarily of a rise in temperature, pressure, or pain. So our aim with electrical stimulation is to achieve A beta activation, so the nerve A beta, which is type 2 touch, rather than A delta or C. So if when completing the electrical stimulation, your patient says that feels hot, that feels painful, that feels uncomfortable, that feels sharp, then you're not reaching your A beta fibres. So you need to change your parameters. And we can talk the specifics of this during the in-person training day. So you have certain parameters for fast twitch fibre activation, certain parameters for slow twitch fibre activation, and according to your EMG assessment findings, you will know which one you want to focus on. When completing the electrical stimulation, you want to make sure that the patient feels the movement of the muscle, feels the pins and needles or tingling, but doesn't feel heat, over pressure, pain, or sharpness. So in your Maple handbook that you receive when you purchase a Maple, there are some preset electrical stimulation programs for underactivity, overactivity, urgency, pain, high frequency, and pain, low frequency. Those are all set within the Maple app on your iPad, and you can use them and tweak from within there. So you can see in the top row, underactivity has a preset of 250 microseconds. That's the phase duration or length of the pulse of electrical stimulation, and a frequency of 50 hertz. But you have a scale there of between 250 and 600 microseconds and 35 to 80 hertz. The phase duration relates specifically to the sensation that the patient experiences. The lower the frequency, the less the patient will feel it. The lower the phase duration, the less the patient will feel it. The higher the phase duration, the more likely the patient will feel it. And remember, we're trying to get to the A beta fibers, nerve fibers, where they feel it, but they don't feel pain, discomfort. So at 250 microseconds of phase duration, they may well not feel it, and you get to your top capacity for electrical stimulation current, and they cannot feel what's going on. That's not pleasant for the patient, because the patient wants to feel something happening. And also, we want electrical stimulation to encourage connection with the muscles. So sensation is important. So we'd stop that program, we'd come back out of it, and we'd change it maybe to 300 or 350 microseconds and try again. And if then they feel something but no pain, and then they can feel movement within the muscles, then we're on to a winner with that setting. The frequency then relates more to the muscle fibers that we're activating. From 35 to 50 hertz, we will be activating the slow muscle fibers. From 50 hertz to 80 hertz, we will be activating the fast muscle fibers. So it's important to make sure that you've got your frequency, your hertz, at a setting that is appropriate for the patient and for the muscle dysfunction that you have in front of you. So if you want to focus on slow muscle fibers, you will be in the 35 to 50 hertz range. And if you want to be in the fast muscle fiber region, then it will be the 50 to 80. Because 50 is the overlapping score, it's very rarely used in the electrical stimulation. So we can go through these specific settings, and you can try them out during the Maple Basic Day. So here is a reminder: the fast twitch frequency will be 50 to 80 with a phase duration of 200 to 400 microseconds. And then the slow twitch fibers are more likely to activate between 35 to 50 hertz frequency, and then a phase duration of 200 to 400 or 600 microseconds, depending on the sensation that the patient experiences. If the patient is experiencing too much sensation and is experiencing pain, heat, or sharpness, then reduce the phase duration to make it more comfortable for the patient so that they can connect with the treatment more effectively. So there is a link there to Physiopedia site on gait control theory of pain. That's a good video to watch. This is just an image of the YouTube video, but you can see there an image of how the pain gait theory works. So we have a gait control theory and an endorphin release theory. The gait control theory is high frequency pain relief, and the endorphin release is low frequency pain relief. So you can see there with the gait control theory, we're trying to stimulate the type 2A beta fibers. So those are the touch sensations, to activate the inhibitory nerve fibers of pain in the dorsal horn of the spinal cord. So we are inhibiting the pain fibers of that nerve by increasing the sensation of the touch fibers, which does not include pain. So we're reducing A delta and increasing A delta or C fiber, and we're increasing A beta fiber activation. So to do this, we need a high frequency. We need a frequency of 80 to 100 hertz with a phase duration of 80 to 200 microseconds. And again, that phase duration, if it feels too sharp for the patient, then bring the phase duration down. This could be completed for between 15 to 30 minutes. It could be several times a day, but obviously in a clinic setting, that is going to be difficult. But it should be on a continuous or cycle. So you can have it with contractions or without contractions. But in my practice, I tend to use continuous more so in the early stages, so that the patient can get used to that sensation and the effects of the treatment. For the endorphin release, endorphins are secreted by the hypothalamus and the pituitary gland in response to a pain stimulus. So here we're using low frequency with a phase duration of 400 microseconds. So with the frequency of 2 to 4 hertz, they will feel a pulsing sensation. They will be able to feel the individual pulses more likely than with a high pulse rate. So the intensity is increased to a point where the patient feels a twitch, and this is always on a continuous setting. There is also a setting for treating overactive bladder and bladder urgency. Here we would choose the 6 electrodes of the anterior plate and the 6 electrodes of the left plate, but we would rotate the probe to the left by an 1/8 turn. So it wouldn't be a full quarter turn, just an 1/8 turn. So then that would be treating the bladder in particular, and here we are treating smooth muscle sensory nerves. So the frequency is 8 hertz, the phase duration is 1000 microseconds, and the duration of treatment should be 20 to 30 minutes. The patient can be left for this treatment, but not left in a room on their own, but you can continue to do your notes while the patient is on the treatment, as long as the patient is within earshot to be able to tell you if the electrical impulse current should be increased or reduced depending on their comfort. So you have this in your Maple handbook, which is how to use the preset programs, but you can tweak the programs within that as needed. Here's a PDF of some research relating to the principles of electrical stimulation for muscles, and it talks about the Ohm's law. And this is the reason why the current for Maple electrical stimulation is capped at 29 milliamps. In a Kegel 8 probe, I think it's capped at 90. Possibly Neurotrack is the same. Pericom, I think maybe 50 milliamps. But because there are 24 very small electrodes, the surface area is quite great. And Ohm's law states that the size of the electrical current varies directly with voltage and inversely with resistance within the circuit. So the capping of the milliamps at 29 is for your patient's safety, so that if they do move or if contact or connection changes, there won't be a surge of electrical input into that pelvic floor causing pain or heat. So the maximum current is set at 29 milliamps for any electrical stimulation with Maple. It avoids a max peak of intensity if the resistance drops. So higher peaks could be uncomfortable or painful. So it is for your patient's safety and comfort. Here we have fade in and fade out. So fade in is how long the electrical stimulation takes to reach its peak intensity, and the fade out is how long it takes for that intensity to drop away. In Maple at present, the fade in and the fade out are always the same figure. So if it's a longer fade in, it'll be less noticeable and more comfortable. If it's a shorter fade in or fade out, it's more noticeable and you have greater sensory awareness. So it's worthwhile just thinking about that. If, for instance, you've got the need to improve fast fibre activation and fast fibre release, a shorter fade in, fade out should be better. But if you've got someone who is nervous or who is dealing with pain, then a longer fade in, fade out may be more comfortable and appropriate for that patient. So again, it's a case-by-case setting. With your electrical stimulation, you can have different electrodes activated to target different areas within the pelvic floor. So you have a ring-to-ring option. So here in the bottom left picture, you can see blue and green for rings 5 and 6. So here, for instance, if you're treating the external anal sphincter, You can treat by ring to ring with rectal insertion of the probe, and you are activating the external sphincter by switching on only electrodes 5 and 6. If, for instance, you want to focus on the front and left side of the pelvic floor, if that on assessment was showing signs of underactivity or overactivity, then you could use a side-to-side approach and switching on the anterior or left plate. You could do the same with left and right, or right and posterior, right and anterior, left and posterior. You can also use a side-to-side one-to-one option. So that would be any 2 plates with a one-to-one variation of the green and blue electrodes, and then side-to-side 3 to 3. So you can see how the electrode current passes. So as the current increases, that red arrow will increase in size, and you can see which areas would be affected by using different electrode choices for the electrical stimulation. So this takes a little bit of practice. This is something that we can practice in the training day face to face, and it is best to try and work out what it feels like when trying this yourself. So when you do get your Maple device, you can try this out on yourself, vaginally or rectally, or both, and see which works best for different areas of the pelvic floor. The ring to ring is the area that I would use most specifically when trying to target certain muscles. So in terms of electrical stimulation troubleshooting, we need to think about, have you got enough gel on the probe? Is the probe in the correct position? Do you need to adjust the phase duration, taking the phase duration down if it's too uncomfortable, or increasing the phase duration if the patient is unable to feel anything? Do you need to adjust the frequency to target the muscles specific to the problem? Or do you need to switch the electrode choice from ring to side, for example, to access the sensations necessary within that area? Okay, so that's the end of this webinar. Thanks again for listening. It is a lot of information to go through, so feel free to pause and rewind and take notes. Write down questions and bring them with you to your basic training day in person, and feel free to practice if you do have a Maple device, and practice these techniques so that you can feel the difference yourself. We'll come back with some clinical discussions in the next webinar.